along the way we learn about a few things, which includes a little bit about alveolar gas equation. We'll learn a little bit about P 0.1, compliance elastance, work of breathing, and transpulmonary pressure. These are things that are very basic, and will help us when we understand ARDS. Okay, we'll understand what the ARDS. Okay. Now, what is the alveolar gas equation? It is this P. These terminologies are important for you. PaO2, that is a capital A. When you see capital A, it means the oxygen that lies inside the alveolus. When you see small a, it is a partial pressure of oxygen inside the blood. When you see small a, it's partial pressure of oxygen inside the blood. So as we discussed, blood in and blood out, the alveolar gas equation is A minus A, that is capital A, that is alveolus, minus arterial oxygen, okay, gradient, minus PaO2, that is alveolar, minus PaO2. This is what the entire thing is all about. Let's go to this to understand what this is about. So this is PaO2, right? This is PaO2. So this equation, PaO2, this PaO2 is alveolar PaO2. How do you calculate? By this equation. If you want to calculate the PaO2, that is how much gas is there in your system presently, how much gas is there in your alveolus presently sitting here, you have to multiply the FiO2, that is 21% here, Pb, that is the pressure, that is the 760 millimeters of mercury, minus H2 that is 47, that is the amount of pressure that is there inside of water, minus PaCO2 divided by 0.8, right? So that PaCO2 divided by 0.8 is regular diet. Regular diet means 0.8 आता है अपना respiratory quotient. That's why it is 0.8. समझ में आ रहा है ना? Are you understanding this? Let's go ahead. What is the FiO2? Okay, this is the FiO2. This is the PbO2. The Pb, that is the pressure. This is the water pressure. Humidity, that is, and PaCO2 divided by 0.8. Clear? What is normal? Less than 15 millimeters of mercury is normal in the gradient. If the gradient is more than 15, that is PaO2 minus PaO2 is more than 15, then you are basically dealing with either a diffusion defect, a VQ mismatch, an intracardiac shunt, or increased extraction ratio. These are the four things you are dealing with. If by any chance, if you're thinking of the A gradient, you understood? PaO2 minus PaO2, that is P capital AO2 minus P small aO2, the normal gradient that you have is 15. So today when you go back to the hospital, to the ICU, you find the P gradient to be less than 50, you can reasonably assume that things are stable. Okay. However, in your pneumonic patient, in a patient of pneumonia, there is going to be a diffusion defect. There is going to be probably a VQ mismatch, and that is why your abnormality comes in, where your PaO2 minus P small aO2 becomes more than 15 millimeters of mercury. But what we understand from the alveolar gas equation that we had in the past was the fact that this completely depends on the atmospheric pressure, isn't it? It depends on the atmospheric pressure. That is why it is dependent on FiO2 and is dependent on barometric pressure. Right? So this equation will change at different parts if you are. For example, if you are here, if you are at Mount Everest, there is going to be a change. For example, atmospheric pressure at 475. Okay, 475, that is, it's low, right? Very high up, the atmospheric pressure is much lower. So 475, the PaO2 over there is 58. The PaCO2 is 20, capital AO2 is 65, which should have been 100, isn't it? FiO2 is 21, FiO2 21%. So the PF ratio remains normal. 26 to 76, where A gradient is very low. So at a high altitude, the PaO2 minus PaO2 gradient changes. Understanding? The gradient change. Whereas you go down into the sea, what's normal? This is normal. We are at 760 millimeters of mercury at sea level. We are at sea level. PaO2 is 58, PaO2 is 20, and that's why the A gradient is very good. Excellent, isn't it? A gradient is very good. Alveolar gradient is very good. Clear on the 66.7, right? Whereas when you go down, even further down, the PbO2 becomes very high, the A gradient actually changes. That's the difference in the A gradient. Clear on this? So now let's go to this. What about shunt? Okay, so PaO2, say this patient is a normal person. If it's normal, his PaO2 is 50, for example. His capital AO2 is 100. His capital AO2 is 100. A gradient is 100 minus 50 is 50. That is what it is. Shunt is unchanged. Now let me introduce a shunt. Okay, I am now going to introduce a shunt over here. The moment I introduce a shunt, even if there is a shunt, whatever is going to happen, even if there is already a shunt there, right? Now even if I put a 50% shunt there, even a 50% shunt there, the A gradient will actually go up majorly. You see this? PaO2 is 377, means the content is gone higher because it's not picking up. Okay, PaO2 is 50, this is unchanged. Shunt becomes unchanged. You got the point? So that's the reason that the A gradient can be used to understand shunt physiology. Alright? You understand, huh? Shunt physiology can be understood here. So normal A gradient for any patient is age in years divided by 4 plus 4. Clear? Age in years divided by 4 plus 4 is your normal AA gradient. So if you want to check for a 60-year-old gentleman, 60 divided by 4 is 4 ones are 4, 4 twos are 8, 12 plus 4, that's around 16. So it varies by age. Okay. So now what you understood from the regular gas equation depends on pressure, depends on FiO2, and it also depends on age. There are 3 things. So simple. These are the only 3 things you need to understand of regular arterial oxygen gradient. Alright. So now that we understood regular gas equations, let's go and understand compliance elastance. Okay. Let's go to compliance elastance over here. So compliance is, there are a lot of terminologies when you talk about compliance. Okay, compliance can be anything actually, it's all Hindi terminologies and all. Manyata, Amsa, it's not that word. But this is what compliance is all about. To inflate, okay, the ability to inflate, distend or stretch is compliance. The ability to inflate, distend or stretch is compliance. Clear on this? That means to say if my lungs are stiff, my compliance will be low. If my lungs are, if I have got extrathoracic compartment that is full, very stiff, it is difficult to distend, my compliance is low. Clear on that? Compliance. Alright, so the ability to inflate, the ability to distend, and the ability to stretch. So what do you understand by so if you're not able to inflate, not able to distend, not able to stretch, then the compliance is low. This is what compliance. If it's low, it is not inflating, it is not inflating. You got the point? This is what it's not inflating at all. How much of your pressure remains the weight is not really changing. That's compliance. Okay. Whereas the ability to return back, it is not even returning back to its original, no? It is not returning back to its original. Because if it returns back to its original status, the ability to do that is actually called as elastance. The ability to get back to its original size or original shape is called as elastance. That means it describes the recoiling force of the entire lungs. You are understanding, no? The recoiling force. If it comes back to where it was, elastance is good. Understood? So there is a difference between compliance and elastance. Compliance is the ability to distend, and the elastance is the ability to get back to what it was. Clear? So in short, compliance and elastance are actually opposite to each other. Nothing more different, it's just opposite. So 1 upon elastance is equal to compliance, so 1 upon compliance is equal to elastance. Okay, clear on this? Understood compliance? So when you say increased elastance, it actually means decreased compliance, means stiffer lungs. When we say decreased elastance, it means it is with increased compliance, it means more easily inflatable lungs. They are both 2 different things. Okay, they are 2 different things, but you must understand this. What is it? Because you hear this very often. But we don't talk elastance. If you go to the European Union, people talk more of elastance. If you talk to the Americans, they talk more of compliance. Okay, so compliance actually, if you are compliance, most important about compliance, what is, why I have put this here? Because it's a very beautiful term. Okay, and what is important about compliance? It gives you the energy cost of breathing. Okay, it gives you the energy cost of breathing. The energy cost of breathing is given by compliance. That means if you have a low compliance, the cost of breathing or the amount of power you need to actually respire becomes very high. That's why a person tires out. Okay, now let's go to a little more basic on that. The compliance actually means a change in volume by a change in pressure. Okay, change in volume by a change in pressure, and you want to correct it, you can actually do it corrected this way. That is peak inspiratory pressure into compliance of the let's forget that, volume divided by pressure. Okay, that's what compliance is. So if I will put this analogy into of compliance to what you do on a daily time, see this is your morning shift. Okay, in your morning shift, your 5 central lines per hour. That's the speed in which you will be able to put it. But by evening shift, it becomes 1 central line in 1 hour. What does this mean? It just means that you are more compliant in the morning. That means more volumes per centimeter of water. Whereas in the evening, it's less volume for the same pressure. For the same pressure, you are actually creating much less volume. You are understanding? Much less volume. So better the lung compliance, better the energy efficiency of the lung. So you are comfortable if your compliance is more than a 60. You know this patient is not going to tire out. But if your compliance is 40, 30, this patient is going to tire out because it's not efficient enough. It's not efficient enough. Clear? So now lung distensibility actually depends on 3 things. Elastance. Now we talk about compliance as the ability to distend. Now what does this compliance depend on? We understood why having good compliance is good. We understand that what poor compliance does to your body. We've understood that compliance is a term that gives us how efficient your respiratory system is. But what exactly is this compliance? This compliance is actually something with respect to elastance, something with respect to resistance, and something with respect to inertia. That is, the distensibility is dependent on these 3 things. Alright, so let's go and take an example. Alright, so anything, so this is how your lungs are. That's your alveoli. Okay, anything that affects the flow of the gas, anything that affects the flow of the gas, like an obstruction, anything that affects the flow of the gas will actually impair the compliance. Anything that affects the flow will impair the compliance. Okay, so that means if I have an obstruction there, okay, it will prevent the distension of the lung. So that means anything that has resistance will prevent the compliance. And this resistance that we have is called as elastic resistance. This resistance that we have, this airway resistance or chest wall altogether is called as elastic resistance. Right? This is airway resistance, and this amount that reaches to upper, that is elastic resistance. Clear? I understand. This is airway resistance, and the amount of pressure it takes to take this up is the elastic resistance, because elastic resistance is for it to get back. That's what we discussed, right? Elastic resistance is something that causes the lung to fall back to what place it was. So take it up, it has to fight against elastic resistance and at the same time fight against airway resistance. Clear on this? Understood this? What is elastic resistance? What is airway resistance? We've understood that? Okay. So anything that causes a increased airway resistance, or anything that prevents the expansion of the lungs, will actually decrease the compliance. So when you see a low compliance, you should start thinking what is happening. Is it the airway resistance going down, or is it the chest wall elastance that is going up, that is preventing the elastic resistance going up, that is preventing my compliance, preventing my distensibility of the lung. Clear on this? Clear? This is complete basic. What is decreased compliance? Right? Now let me take off this. This is what is airway resistance. Right? This is what is airway resistance, and this is what is your elastic resistance. Clear now? Clear? So if you find a low compliance, you should start thinking what's happening. You just don't look at compliance, because when you say compliance, you always think of just maybe lung is not okay. Maybe it's just what you have to think like this. Okay, you have to think like this. Alright. And what does this airway resistance depend on? If I ask you, what does this airway resistance depend on? It actually depends on the length of the tube and the radius of the tube. It will depend on the length of the tube, the radius of the tube. That means to say, if you have bronchoconstriction, the radius of the tube is going to go down, which will cause a reduction in the compliance. Clear? Clear on this? It also depends on the gas. It also depends on the viscosity of the gas. Now, there is an application of this in critical care. So, if you have a patient with bronchial asthma, and now I want the gas to move in much more easier, I will probably use helium, which has got a low density. Okay, when I have a lower density, the gas will move in much more lesser with a lesser resistance, lesser airway resistance, laminar flow. So, it also depends on the viscosity and density of the gas mixtures, this resistance. And of course, if you put this patient on the ventilator, it will depend on the flow rate and the flow pattern. You understand? If you to explain this to you, say you have a patient on a 1:1 ventilation. Weight is say I've got a tidal of 500. I've got tidal of 500 and I have a 2 seconds of inspiration and 4 seconds of expiration. That is 1:2. Okay, so 500 ml is going in 2 seconds. 500 ml is going in 2 seconds. Now I make this 1:1. That means 3 seconds. So same 500 ml is going in 3 seconds. So obviously the flow rate will come
down.
When the flow rate comes down, the compliance improves. So if you have a patient whose compliance is on the lower side, okay, you can manipulate the compliance by looking at resistance pattern, and that is the reason that when your peak pressure goes up, at the end of the day, when I go back to that same equation that I showed you at the start, let's forget it. This equation, when the peak pressure goes up, there is going to be a drop in the compliance. So to improve the compliance, I will need to get my ventilator flow rate down with respect to airway resistance. Right? Clear on this? It is very similar. This ventilator flow rate is very similar to what happens in the morning. In the morning, I don't know, you have a tap when you go to wash your face. Very often what happens is I got a pump in my house, a pump which actually activates, which gives flow to, you all are living in high rise. This is a high rise, so you don't have a problem with flow. In my house, I have a problem with the flow of water because my water tank is right above my house. So it doesn't go in. So I got a pump which actually forces water. So every time in the morning what happens to me is, I get up in the morning, okay, very often I get up in the morning, I don't know whether the pump is on or off. Okay, the moment I switch on my water, okay, it just cuts onto my face because of the flow being very, very high. You understand? Okay, this is called as wash basin analogy. Okay, wash basin analogy. Okay, that's what happens with high flows. That's what happens with high flows. It just spoils everything. So that's why you don't want to give high flows into our patients. Okay, now this flow, let's go to also the laminar gas flow that I was talking about when you change the flow characteristic to laminar flow. So if you see this is going straight. Okay, the resistance is pretty not very bad. Okay, but the moment it goes this way, the resistance will change because it's not hitting most of the walls. It's going like this. It's not hitting everywhere. Hitting resistance increases, shear increases, resistance will go up. This is what happens when you have obstructions, mucus plugs, and all of these things. Right? That is the reason that you should not have obstructions, because obstructions will cause, in the presence of a high gas flow, will cause resistance to go up and the compliance to go lower. Clear on this? That's why we want to use the lowest possible flow to actually ventilate our patients. Clear? Understood this? About resistance, we have just talked about airway resistance. Right? And how it kind of affects compliance. So the normal airway resistance that you and me have is somewhere around 4 to 6. This is what our normal is in an intubated patient. So you have a resistance in your ventilator. See it. It will show you that. It will show you somewhere around 4 to 6 is what you are going to see in our patients. It becomes significant when the resistance goes more than 50. And how do you estimate the airway resistance? Peak inspiratory pressure minus plateau pressure divided by flow. That is why higher flow. You understand what I am saying? Clear on this? Clear? So that's all about resistance, right? That's all about resistance. Let's go to elastance now. Understood resistance? Now we're going to elastance. Okay. So you remember the diagram. Elastic resistance. We just talked about the resistance of the airway. We finished this part. Now we are going to this part where we have elastic resistance there. Going to elastic resistance, right? Now the elastic resistance will actually depend on alveoli, isn't it? It will depend on alveoli. If your alveoli is full of pulmonary edema, fluid and pus, it is going to have a difficulty, right? So it depends on the alveoli. Okay. Then it depends on interstitium, right? And it depends on the chest wall, isn't it? It depends on the alveoli, it depends on interstitium, and it depends on the chest wall. Clear? That is why in cases of interstitial fibrosis, alveolar fibrosis, patient position for that matter, if you put the patient in a down position, the abdomen will come to the top. This will press, right? This will press. Atelectasis, because again you got the alveoli to be collapsed and problems over there. Loss of surfactant, which you see in patients of ARDS or in patients who are very young, neonates, trauma and pain, you're going to have a reduction in your compliance because elastic resistance goes up. Clear? Clear? Anything? You understood this? So that's why ascites. That's why when you are ventilating a patient, if you know all these things, you probably pay more attention to what's happening. You pay more attention to the numbers that you see on the monitoring of the ventilator. All these numbers are given on the ventilator, right? Now this compliance is further divided into two parts. It is the static part and the dynamic part. So static compliance and dynamic compliance. Static is when there is no flow, dynamic is when there is flow. So let's go and understand. Change in volume divided by change in pressure is compliance. We discussed that. Change in volume divided by change in pressure is compliance. Now, static compliance is basically what? Elastic resistance. Okay, that comes in from lungs, plateau pressure, transalveolar pressure. We can figure out from transalveolar pressure, from plateau pressure and lungs, the elastic resistance that is coming in. This is what is static compliance. Okay, we do plateau pressure and we get static compliance. When you see C on your ventilator, we note down compliance. It is static compliance. When I say static compliance, the airway resistance is not there. That's why when you do inspiratory hold, there is no flow. When you do inspiratory hold, there is no flow. So that means you remove the airway resistance part. It is only the top part that we in the diagram that I talked about. That is you understood the elastic resistance. When I am removing my flow here, right? I am removing this part. When I am doing an inspiratory pause, this is not there anymore. There is no flow. So what is my ventilator? Which pressure is my ventilator seeing? That thing. Elastic resistance. Okay, so it's static compliance. Clear? It is static compliance because there is no flow anymore. Clear? Clear with this? Static compliance. So it will tell you about the lungs. It's from plateau pressure and transalveolar pressure. Whereas elastic resistance plus airway resistance is dynamic compliance. Right? So when you see C dying on the ventilator, it is dynamic compliance. When you see C stat on the ventilator, it is static compliance. You understood the difference? You understood now from basics airway resistance plus come from the elastic resistance. When you actually combine airway resistance and elastic resistance, you get dynamic compliance. And if you minus the airway resistance out of it, you probably get elastic resistance or static compliance. Clear? You understood this simple basic thing? So you can imagine the amount of information you can get if you know the monitoring that is there on the ventilator. The amount of information you can get is so amazing that you can probably figure out what's happening to your patient if you understand these important things. That's why when you go on the ventilator, it's important for you to write down these values. And why it's important? Because you understand what's happening.
So we can kind of find out the airway resistance by the sound.
Yeah, yes, you can. So today, if I have a patient with a static compliance, okay, of say 50 and a dynamic compliance of say 80, I'm supposed to have only 4 to 6 of resistance. But I'm having 80 compliance. That means it's not a majorly up. Means what am I dealing with? Rock demonstration, isn't it? It's something that you can easily figure out when you're actually on bedside. You don't need anything too much. You understand? So this is why you must know these simple things. And that means to say, if I want to calculate dynamic compliance, what do I look at? Where I'm looking at plateau pressure. There what I look at? Peak pressure. It has to be peak pressure, isn't it? Because it is the airless pressure I'm going to look at. So here I'm looking at peak pressure. Here I'm looking at plateau pressure. Clear? Clear on this? Static compliance and dynamic compliance. So when I go to the curve, let's go and understand this a little bit more better. So this is the pressure time curve. This is P1, this is time, this is resistance. Alright. The pressure at this moment, the ventilator is saying is P1, P2 is there, the pressure of the alveolus is there. P1 is airway. This is the resistance of the airway. So let's go to our graph. This is our graph, our pressure time graph. Pressure and time. Pressure versus time. This is a pressure time graph on the ventilator. So once the gas starts moving, means what is happening? P1 is more than P2. But this will not move, right? Okay. So clear now? For the gas to move, it has to go from high pressure to low pressure. So it's going to move from. So I'm going to make P1 greater than P2. That's what happens when you start the breath on the ventilator. Okay, you start the breath, you have this first wave that goes up. P1, P2. Pressure has gone up. That's why pressure has gone up. Clear? Clear on this? Pressure has gone up, understood this much? And why is that occurring? Why is the pressure going up? Because it is the flow that is moving inside. The flow has started moving inside. That's why the pressure has gone up. Clear? So now if I think like this, that if this goes higher, means the flow is more higher. That means there is probably resistance of the airway. You understand? Because in the same volume has to go in the same time, what has to increase? Flow. If the same volume has to go in the same time, what has to increase? Flow. So if that means to say if my flow is going up, what is going to go up? Pressures. So that is why resistance of the airway reflects as peak pressure. So that's what occurs. The alveolus expands. Okay, that's why you initially have a steep curve and then you have it slightly going this way. The reason it goes slightly this way is now it's a bigger area. So the pressure rise is not too much. That's why it goes up. And this is what we look at in the ventilator called as stress and strain. When this goes up like this, means what? Flow is happening, but the alveolus is not increasing. That means this patient requires, he is pulling more. He is pulling more. That's why it's going down like this. That means there is a stress or strain on the ventilator. Okay, so this is what is compliance. Now what happens next? Suddenly this P1 and P2 will change because till now pressure was more here in the airway, pressure was less in the alveolus. Now what is happening? P1 has become equal to P2. What happens if P1 is equal to P2? Flow will stop. There is no more flow happening. So what do you get in the ventilator? You get this. The flow just drops, the pressure just drops and reaches this particular level. Now at this level, there is no flow. P1 is equal to P2. That means this is reading what? It is reading this pressure. And that is your plateau. Got the point? This is where you are seeing your plateau pressure. That's why when you do inspiratory pause, I am stopping the flow. When I stop the flow, my pressure that I am reading is there, and that pressure is plateau pressure, which we discussed as static compliance. You understand? We discussed as static compliance. Clear? Then what happens in the next part of the circle where this P1 becomes more, passive expiration starts. Okay, P1 becomes lesser, that is passive expiration starts, the pressure is increasing, the patient starts breathing up inwards, right, in passive exhalation. And then what happens? Suddenly the air moves this way and you have this lower wave. Clear? That is how the entire pressure tracing is created on your ventilator. The pressure time tracing is created this way on the ventilator. So then you will, by looking at this waveform, you may be able to understand on a volume control mode you may be able to understand which phase, where, what exactly is happening if you understand this particular diagram that I told you. Right? So now can you tell me where the elastic resistance is on this diagram? If I ask you now, on this diagram down there, where is elastic resistance? Where elastic resistance is minus the airway, right? Elastic resistance is minus the airway. Airway resistance plus elastic resistance is total resistance, is total compliance. Where is elastic resistance here? Sachin, can you point it out?
It's coming down. Downward slope.
So here we stopped it.
Yeah.
There will be no flow. Then the resistance come down because there is no flow. So what approximates at the end is elastic resistance. This is elastic resistance. Clear? Huh? So you have the elastic resistance coming over here. You understood now the entire waveform? Okay. That's why when you say static, it is plateau pressure minus P, whereas dynamic is peak inspiration minus P. And with this, you can have a lot of mix and matches. Actually, you can have a lot of mix and matches. You can actually figure out what happens when there is decreased compliance, with decreased static compliance. There are a lot of things you can figure out what is happening. There is a lot of combinations you can get in this, which will give us ideas as to what each of this is meaning to do. Clear? So now we understood compliance and elastance. You understood compliance and elastance? It can't be made more simpler than what I did just now. Okay? So I hope you've understood compliance and elastance as of now.
Elastance and elastic resistance are the
Same.
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 And they are inverse of
Compliance. Clear? Now let's go to P0.1. Another very important thing that you have. P0.1. On the ventilator, you got something called as P0.1. On the ventilator. Now what is this P0.1? So on the ventilator, what happens is at 100 milliseconds, in 100 milliseconds, the ventilator figures out the pressure that's coming down. That is 0.1, P0.1. Maximal slope, that is the slope over there, right? They've drawn a slope over there. The ventilator calculates the maximal slope of the airway pressure drop during the first 100 milliseconds when the airway is occluded. Okay? I'll explain to you what. At this moment, there is no breath happening. The airway is occluded. There is no breath happening. There is nothing happening here. It is just stopped. You know, just when the patient is taking a breath, the valve has to open. The ventilator valve has to open when the patient triggers, so that air can be taken inside. What the ventilator importantly does, it actually sees this drop before the valve opens, okay, and calculates the slope. This slope at 100 milliseconds is called as P0.1, which actually gives you inspiratory effort. Clear? Inspiratory effort and drive, or the work of inspiration. Okay, people use it for inspiratory effort, not very well proven for that. It gives you the drive. Alright, it gives you the drive over here. It's a mechanical index of the respiratory drive. It is a mechanical index of the respiratory drive where if it is more than 6, minus 6 on your ventilator P0.1, more than minus 6, it indicates that the patient is taking too much of effort, too much of drive, increased workload. Clear? That's why when you have weaning, look at P0.1. You have some kind of an estimate what is happening. It will help you to understand what is happening. So P0.1 is seen on the ventilator by a small button that you just press and you can see P0.1. It comes calculated in certain ventilators without you pressing P0.1. For example, the new ventilator that we have, the Hamilton C6 that you see over there, Hamilton C6, that gives you the P0.1 even without you presenting a button. Understood P0.1? So if I were to put it this way, the calculation is like this. Make you understand what happens. This is the trigger. Okay. So CPAP mode, there is a trigger happening. In the first 100 milliseconds, it actually calculates the slope over here, and that is your P0.1 before the inspiratory valve opens. Clear? Before this, so the 100 milliseconds before the inspiratory valve opens is called as P0.1, which actually gives you respiratory drive, right? And they did find they used it. How do they use it? Some people have used it to actually target their pressure support. The effort to target the pressure, to target the effort. For example, this is the relationship of the work of breathing versus the P0.1 with respect to changing of pressure support levels. So as the pressure support level comes down, the P0.1 comes down. As the pressure support level comes down, the P0.1 comes down in weaning. You understand? That's what they are looking at. Yeah, as the patient is weaning, okay, they are able to do this. Okay. So it may be used as a technique to set your pressure support ventilation. You got the point? It may be used to actually set your pressure support ventilation. You can look at your P0.1 and set. So if your P0.1 is very high, effort is too much, I can't reduce my pressure support. Let the pressure support be high. But if my P0.1 has started coming down, maybe I have a good reasonable chance that I may be able to reduce the pressure support. You understanding? I have my P0.1 is giving me my drive as well as my effort. Okay, if my P0.1 is very, very high, it is not the right time to actually get this patient off the ventilator. Probably the effort is too much. Let it be on the pressure support for some more time. But if the P0.1 has started coming down, it is very well, no problem at all. The drive is good, everything is perfect. I can come down the pressure support. Clear? In fact, this was a more sensitive pattern to actually detect the effort rather than you looking at the patient. See, normally what we do, we look at the patient. We do look at the patient. But when they actually did a study where they looked at the patient, okay, they found out that by airway occlusion that was due to dynamic hyperinflation, they actually did that to look at the patient, and they found that it was a much better tool. But however, it is used maximum in COPD. It is used maximum in the weaning time at COPD. The maximum evidence that you have is during COPD. That means when you have P0.1 to be high in patient of COPD, the chances of extubation and failure are very, very high. So P0.1 is something you want to look at. So here there is P0.1 was high, okay, the chances of extubation and failure was very, very high. Understood P0.1? Okay, that's what basically it said. Even when you look at it, it was almost equivalent, almost even in fact slightly better than rapid shallow breathing index. Rapid shallow breathing index is respiratory rate divided by tidal volume. On your head, you get that rapid shallow breathing Coben's index, we get it on the ventilator. Here the area under the curve is 0.53, means 50% of the time should be right. This is slightly more higher. You saw? And when you actually multiply this and this in a figure, the specificity sensitivity gets even more better. The combination of P0.1 and rapid shallow breathing index will actually help you to wean your patient. That's why when I say put down weaning criteria, you should be putting down the P0.1 because it gives me a reasonable estimate as to what's happening. Right? That means the P0.1 can be used for drive, it can be used for effort, and to understand effort a little bit, not much as drive. A drive is the perfect, and settings of the ventilator. Clear? Clear? So now we have understood compliance resistance, we have understood regular gas equation, we have understood P0.1. Let's understand work breathing. Alright. So the entire work of breathing is actually dependent on how much work is required to go against the resistance, okay, and how much to go against the compliance work and resistance work, right? So how much do you think is the, other 100% energy is what you have, Elizabeth, how much do you think you spend on breathing? How much? If 100% of your breath, 100% of your energy, you have 100% energy, how much at this moment is going for breathing? How much? 60 to 80%. That you have to think every time. You just sitting here. You don't even think while breathing, right? You just breathe. How much? Yeah, it's very low. It's 3%. It's barely 3%. You sitting over here and breathing is barely 3% of the total energy. You understand? It's only 3%. That's why you are breathing without thinking, without effort. That means to say, if the person is having effort, you can imagine how much is being spent. If that means to say that if the patient is having effort, having a RR that is high, imagine how much is getting spent energy. Huge amount is getting spent. Because actually you spend only 3%. Right? And that 3%, actually, if you divide them, 65% goes in this. In elastance, actually, compared to elastance, that is my chest wall, my lung, and only 35% goes in my airway resistance, if you want to divide it. So 65% goes. So that's why if I get obese, I have more difficulty in breathing. That's why, if you understand, if I get obese, if I am kyphoscoliotic, okay, I have more difficulty in breathing because 65% of my effort goes in elastic resistance. 35% goes in airway resistance. Clear? Clear? Elastic versus airway resistance. Then when you say airway resistance means turbulence of tubing, rock constriction, only 35% is actually used in that. That's why an emphysematic patient is more serious and more difficult and more thinner than an asthmatic patient. An emphysematic patient, a COPD patient, is usually more thinner, right? Why are they thin? Why are they thin?
Energy expenditure is
Exactly. The entire energy is getting spent in overcoming elastic resistance. You understand? The entire energy spent in overcoming elastic resistance because the chest wall is stiff. He is not able to expand, and that is the reason that they are thin. You understand? That is the reason they are thin. That is the reason that if there is a person who is having COPD or if a person is having emphysema, I want to feed them very well. Their energy requirements may be much higher. Are you understanding? You got the point? That's why you see, if you have a patient of COPD coming to you, if you feed them well, 3 months later their 6-minute walk test will improve. If you feed them well with a good calorie load, people think this way, that COPD, if I give calories, carbon dioxide will increase. No, it is not like that. It is not at all like that. Why is he thin? He is using that energy. He is using that protein. The protein is getting down. Lean body mass is coming down. Are you understanding? You give him that energy, proteins will go up. Lean body mass will go up. He will not use his proteins up. He will become more active. He will walk better. Are you understanding? That's why COPD patients have to be taken care of on the nutrition. This explains the resistance work that is pre-IP minus P plaque. Reduced compliance means increased work of breathing. Clear? Reduced compliance means increased work of breathing. Okay, so this is giving you an airway resistance and airway. So in the earlier airways, the resistance is very high. The earlier airways, first, second generation airways, this is the conducting zone. This is from where it reaches the alveoli. So this is the airway resistance, and this is the elastic resistance. Clear? So the work of breathing maximum is during your airway resistance time. Okay, that is the airway resistance gives you in the starting. Then it is the elastic resistance, and that's what you see here. This part of the entire force is elastic. This part of the force is airway. In your graph, when you see a loop, a pressure volume loop, pressure versus volume loop, this is the inspiration, peak inspiratory pressure. What will it give you? Airway resistance. That's why this part is airway resistance, inspiration, expiration ka aadha. This is airway resistance, whereas this part is your elastic resistance. 65% is elastic resistance, 35% is airway resistance. So that's why if you have the curve going down, what does it mean? What does it mean? My elastic resistance is very high. Work of breathing is very high. Compliance is low. That's why when you say movement of curves, flow volume loops, other example flow volume loops, we say it goes downwards, what is going to happen? You must now understand why that means. It means that if this goes down, my compliance has reduced. My compliance reduced means what is increasing? My elastic resistance is increasing, which is actually increasing my total work of breathing. Clear? Similarly, when the curve moves the other way around, same thing. If this increases here, this will come here. Okay, that moves upwards. It's the airway resistance that is increasing. It is not the elastic component. Clear? You understood this much? This is the elastic force. Okay, and that would change with optimizing RR, P, positioning, surfactant, and things like that. Where and there is a Campbell diagram that actually looks at something like this. I will not go into that. There is a Campbell diagram that looks at work of breathing. Alright, so now that we finish this, go to the last topic of the day, that is transforming pressure. Okay? So you have so many pressures. We have airway pressure, we have understood plateau pressure, there is pleural pressure, there is transcendental pressure. No, I don't know if you all know the song Slim Shady.
Yes, sir.
Long ago, 1990. Slim Shady. You heard Slim Shady? So it's actually this computer song that actually plays the song when this slide comes. It says Slim Shady, please stand up. When the real Slim Shady, please stand up. So the big thing there is this. So which is the real transfer pressure when they stand up? That's the question. So the lung distending pressure is what my major pressure is what I'm looking at. Because now that I've understood how much it distances your lungs. So that's my work breathing, isn't it? So the lung distending pressure is what I want to figure out. And the real pressure that I'm concerned with is my lung distending pressure. What you get is transpulmonary pressure. That is your actual lung distending pressure, which is alveolar pressure minus pleural pressure. Which is alveolar pressure minus pleural pressure. Okay. Now I explain to you what is happening over here. Till now you have this graph. We will understood this graph related to plateau pressure. We understood this graph. Okay. So it is giving me the pressure of this part. इसका part का pressure दे रहा है तुमको. इधर का part का. हाँ? Clear on this? Is giving you the plateau pressure over there. But what it has forgotten is this part. Where is the pleural pressure? It's not talking about pleural pressure at all. So can I say that my plateau pressure is the real pressure distending? No, it is not. It is this plus this, isn't it? That is the real pressure that is actually. You have to minus this out, right? You have to minus this out because it is not only opening up the alveoli, it is also pushing up the chest walls. It is not only opening the alveoli, it is also pushing up the chest wall. So the entire pressure is used to open up the alveoli and lift up the chest wall. So the distending pressure is, I want only this one. I don't want this one, right? The distending pressure that is exerting on the lung is only the alveolar pressure. It should not be the pleural pressure. Are you understanding? Distending pressure, right? इतना समझ में आया? So this means to say what? If I remove this pressure out, this pressure is what my pressure is my lung distending pressure. समझ में आ रहा है? Clear? Huh? So can my plateau pressure be the right pressure to save the lung? No, it is not. Because plateau pressure is only giving you a combination of lung distending pressure and chest wall distending pressure. I want to know what is my actual lung distending pressure. Right? Clear? So how will I know that? Only when I subtract this pressure. Only when I subtract this pressure, I will know my lung distending pressure, which is my transpulmonary pressure. Clear? And how do you get that pleural pressure? This is what it comes. That's why we use it in implement. You understand? You understand? This is what is esophageal pressure. So inside pressure minus outside pressure is trans pressure everywhere. Inside pressure minus outside pressure. So let's go to this. How to know, to understand this a little bit better. So this is a spontaneously breathing patient. Spontaneously breathing patient. Your pleural pressure is negative. At this moment you are sitting, your pleural pressure is negative. It's minus 3. Okay, your alveolar pressure, if it is say 0, what will happen? 0 minus minus 3. 0 minus inside pressure minus outside pressure. 0 minus minus 3. That is 0 plus 3. That's why there is 3. That's why this is distended. Simple? Now, that's what your transpulmonary pressure is. That's why your distending pressure here is 3. That's why it's distended there. Now let's introduce a pneumothorax. Now let's put pneumothorax here. Once I put pneumothorax, what is happening? Outside pressure becomes equal to inside pressure. That is 0 and 0. So there is a high possibility that if it is 0, your lungs are going to slowly collapse because now the pressure is 0 here. Pressure is 0 here. That's why when you have a patient of pneumothorax, his transpulmonary pressure is 0, he is going to collapse his lungs. Collapse his lungs. Sunbara? Clear on this? Pneumothorax clear? Now let us go to maybe something different. You have a pressure control of 10, a PEEP of 6, and the pleural space is minus 6. Okay? is fluid phase also 6. What will happen here? What is the transmission pressure here? What is the transmission pressure? It's a pressure at expiration, right? So your inside pressure is how much at expiration? What is the inside pressure here? 6. At expiration, your inside pressure is 6. Your outside pressure was 6. 6 minus 6 is 0. What will happen to the emulus? It will collapse. Clear? Clear? Now, this patient was with you in your ICU. Because of the fluid resuscitation you gave, this is going to occur when there is pneumonia, things like that, because the outside pressure is going high, or it's obesity, maybe fluid pressure is high. Clear? Now let me do resuscitation to this patient. When I do resuscitation to this patient, the fluid pressure will again increase. 12 or total effusion. You have no effusion. Now you have to effusion. Now you resuscitate excessively, so all the lung water has gone into the pleural space or in the extrathoracic elastic resistance. So this has gone 12. Now what is the transmission pressure? 6 minus 12. Negative. When transmission pressure is negative, the lungs will
collapse.
Clear? Clear? That means it is a collapse at exhalation. This is exactly what was happening to one of our patients recently. When we put the nutrient inside, we found out no, he's collapsing at expiration, the lady. Isn't it? Collapsing at expiration because transmission pressure was negative. It was minus 15. The transmission pressure was minus 15. When the TPP was minus 15, we never knew that, right? Oxygen is normal. Patient was not getting beam. Remember this patient, right? Patient was not getting beam. Patient beam नहीं हो रहा, पता नहीं beam क्यों नहीं हो रहा? Beam क्यों नहीं हो रहा था? Because his transmission pressure was minus 15. Lungs were collapsed, which we could not find out because oxygen hemoglobin dissociation curve does not change unless your FiO2 really oxygen comes down to 80. वो 90 में बड़ा हुआ था पूरा टाइम. हम लोग लग रहा था 90 है, should have been by not meaning, isn't it? Then what we did? We introduced a nutrient. We introduced a exhalation manometer. And what we found? Transmission pressure was minus 16, minus 17 something. What did we do?
Recruit PEEP, higher PEEP.
So what happens when we increase the PEEP? So what I will do here? I will increase the PEEP here, right? If I increase the PEEP to 12, what happens to transmission pressure? It becomes 0. There's a chance that it will probably still collapse. So I'll have to increase the PEEP further high. Now what happens? The resuscitated goes high, again it will collapse. Okay, 12 minus 20 is minus 8, right? So the only way I can prevent this collapse or exhalation is to actually increase my PEEP. So when I do 10 minus 6 now, the transmission pressure becomes positive and the emulus expands. This is exactly what happened to that patient. Exactly what happened to that patient. We actually did that. Okay, we never found out unless we put the exhalation manometer. We never found out that a possibility हो सकता है, right? There was no way to find because unfortunately the patient was not recruitable also. That patient was not recruitable. Recruitable means distending the lung, whereas PEEP means preventing collapse. They are two different things, right? Here what was happening was not the problem of recruitment, it is the problem of preventing collapse in that particular patient, right? Here, meanwhile, you can't just keep going higher and higher also because it will cause over distension and exhalation. You can't do that too. You want to just keep it slightly positive. You understand? So there are various ways to do this. That's why we do transpulmonary pressure. What is the evidence? Yes, there is evidence that says it reduces length of stay. It is much better than that. However, this evidence will not be major because very few centers in the world use it. Very few centers in the world use it, so you will not get big evidence that says this works, something like that. But we know that there have been many data that has actually looked at this, and I'm certain that very soon we'll get to the answer of this. Another very important part is driving pressure and stress index. Driving pressure is plateau pressure minus P. Simple. Plateau pressure minus P is your driving pressure, which essentially is static volume divided by compliance with the resistance, compliance with the respiratory system. That's your driving pressure. And what we know is that as the driving pressure increases, the relative risk mortality actually increases. That's why beyond 14, the mortality goes unacceptably high. So that's why we want to keep the driving pressure around 14 and 15, right? So that's what it basically says this, that irrespective of increase, if you increase, say for example, I just increase my PEEP. If I increase my PEEP, my plateau pressure minus PEEP, that is delta PEEP is coming down, I will have an improvement of my patient. Plateau pressure minus PEEP. If at the same time you are increasing your PEEP, your driving pressure goes up, there is no chance that this patient is, there is less chance that this patient is going to improve. What you need, the plateau pressure remaining where it is and driving pressure going down. That is what you need to happen. The plateau pressure should remain where it is and the driving pressure is going to go down with an increase in P. That will actually affect improvement in mortality. You're understanding this, right? You're understanding this, right? Driving pressure concept? Right? This is driving pressure concept that we talked about. So if you look at this curve now, you'll understand that this is your driving pressure. Plateau pressure minus P. Alright, so when the compliance deteriorates, your driving pressure will actually go higher. The same volume will cause a very drastic rise in pressure. Okay, that's why the compliance has gone down, the curve has gone down. This is called hysteresis. Okay, curve has gone down. Right? Same kind of volume will increase the airway pressure. That's why finding out whether you are here on the graph or finding out here on the graph makes a difference, and that's what we do by assessing recruitability. We understand where we are. When we know that the recruitable means we are somewhere here, that means if I do something, it's going to go up faster. If there is no recruitability somewhere down here, okay, it's not going to improve. That's the entire thing, right? So, the driver number 6 ml per kilogram, PEEP of 10, but the drive pressure 18, PEEP of 14, drive pressure 14. What is better? Drive pressure 14 is better. Irrespective of what the saturation is all about. That's why driving pressure should be noted down on your daily rounds. Clear? Stress index. We just now explained. I explained to you what that waveform was. Right? I explained waveform. So this slope is plotted. This slope is plotted. Okay. So if this waveform becomes like this, stress index is more than 1, volume runoff becomes higher. Clear? If it is like this, completely like this, at electron is coming. It has to be straight up. Set is at 1. The flow, this has to be the slope of the pressure curve with constant inspiratory flow will let us know the stress index. So this is something you should be looking at your patients who are volume controlled, who are relaxed, not who are making efforts on the body. Right? Clear? So today what do we learn? We learned compliance, we learned elastance, we learned resistance, we learned transforming pressure, we understood about work of breathing, driving pressure and stress. So these are all just physiological concepts. All other concepts that can't get more better than this. Right? Anything further you want to ask about this? If you understood this, after understanding this now,